Hello, good morning, good afternoon, good evening from wherever you are joining us from in this webinar. You are welcome to the Diphtheria Response webinar in the West African World Health Organization African region. You're welcome to this webinar. This is the second webinar we'll be having. The first one we had was on 22nd September 2023. And this webinar is very important for all member states within the African region to be able to respond appropriately to the diphtheria outbreak in which we have. We know that diphtheria is a vaccine preventable disease, and with the low coverage that we've had, we are now having outbreaks in countries. So this session is really to come together and share knowledge and experiences from experts from the World Health Organization and partners supporting this. So we have the Ministry of Health and Nigeria Centers for Disease Control and Prevention that will be part of this webinar. So you are welcome again. Thank you for joining this session. We would move ahead with this webinar. But before we start, please note that this virtual training adheres to the code of conduct to prevent harassment, including sexual harassment at WHO events. We'll be going through this agenda. My name is Olaoluwa Aderinola, anchoring this webinar from the WHO Regional Office in Brazzaville, Congo. This is the agenda, as you can see on your screen. We'll be having this session for 2.5 hours, and we'll be starting briefly with the welcome remarks by Professor Andre Bitter. So he'll be taking us through this, and I'll come back for the remaining sessions of the housekeeping rules. Professor Bitter.
Thank you very much, Olau, for giving me this opportunity to provide welcome remarks. Mesdames, Messieurs, chers collègues, chers participants de la région africaine de l'OMS, c'est un privilège et un honneur pour moi, au nom de la directrice régionale d'AFRO, de vous souhaiter une chaleureuse bienvenue à ce deuxième webinaire sur la réponse à l'épidémie de diphtérie dans la région africaine de l'OMS. Le sujet qui nous réunit aujourd'hui est une grande importance parce que tout au long de l'histoire, la diphtérie a été l'une des maladies infectieuses les plus redoutées du monde, provoquant des épidémies dévastatrices touchant principalement les enfants. La diphtérie est une maladie grave, aiguë, et transmissible des voies respiratoires supérieures, causée par l'espèce Corynebacterium, principalement Corynebacterium diphtheriae, producteur de toxines. Cette maladie est évitable par la vaccination, comme venait de le dire Olaou, et d'une part, cette maladie a ressurgi depuis quelques mois dans notre région, et d'autre part, dans certains pays qui ont enregistré des épidémies. Il faut dire qu'il y a quelques années, c'était des cas suspects qui étaient enregistrés. Alors, cette situation peut s'expliquer par certains facteurs principaux, dont le nombre important d'enfants qui n'ont jamais reçu un vaccin qui contient l'antigène contre la diphtérie, notamment le DTC, ou alors qui n'ont pas complété leur vaccination, ou encore ceux qui n'ont pas eu de dose booster. Vous savez que l'OMS recommande les doses booster à partir de 5 ans, mais ce n'est pas encore véritablement introduit dans la majorité de nos programmes. Alors, en dehors de cette faible protection, surtout des enfants, il y a une forte promiscuité et des mauvaises conditions d'hygiène et de salubrité. Malgré les efforts importants fournis par les pays avec l'appui de l'OMS, des partenaires, la situation de l'épidémie perdure et s'étend même dans de nouveaux pays à risque, présentant les facteurs de risque que je viens de citer. Mesdames, Messieurs, chers participants, Sur le plan épidémiologique, l'incidence de la maladie a considérablement diminué dans le monde entier avec l'introduction de la vaccination que je venais de citer tout à l'heure, notamment avec l'anatoxine diphtérique. Cependant, la diphtérie reste endémique dans plusieurs régions du monde, notamment dans certains pays de la région africaine comme le Nigeria, le Niger, la Guinée et le Cameroun. Tout au long de l'histoire, la diphtérie a été l'une des maladies les plus redoutées provoquant des épidémies, comme on l'a dit, et surtout les enfants qui sont affectés, et principalement ceux qui ont moins de 15 ans. Mais il faut dire qu'on voit dans les épidémies actuelles des personnes de plus de 15 ans et parfois des adultes qui font la maladie. Depuis 2010, les cas suspects se sont multipliés jusqu'en 2023 dans la région. Alors, la situation au 26 novembre 2023 montrait un total de 22 942 cas suspects de diphtérie, avec malheureusement 779 décès qui ont été signalés dans les pays suivants: le Nigeria, la Guinée, le Niger, la Mauritanie et l'Afrique du Sud, avec pratiquement 84% des cas et 74% des décès au Nigeria. Il faut dire que le Nigeria, c'est le pays le plus touché. Les tendances récentes indiquent une augmentation hebdomadaire des cas en Guinée, ce qui contraste avec une baisse dans les autres pays touchés, notamment la Mauritanie, le Nigeria et le Niger. Mais il faut dire que certains districts connaissent une augmentation des cas. C'est pour ça qu'il faut rester prudent malgré la baisse qui est observée. Et il faut dire qu'en Mauritanie, aucun cas n'a été signalé. Plus de 56% des cas documentés ne sont pas vaccinés. Dans certains pays, c'est pratiquement 100% des cas qui ne sont pas vaccinés. Plus de 57% des cas suspects ont moins de 15 ans. Et les femmes sont les plus touchées avec pratiquement 60%. Au Cameroun, 3 cas suspects et 2 décès associés à la maladie ont été notifiés et le pays est en train de pratiquer, de faire des tests pour pouvoir confirmer. L'OMS, pour sa part, soutient le pays de la région sur le plan technique, sur le plan financier et même dans la mobilisation du matériel, des équipements ou parfois alors des réactifs ou bien des antibiotiques. Également dans la mise en place du système de gestion de l'incident, également dans la mise en place de la coordination et le support de la coordination, la surveillance, la vaccination, la prise en charge des cas, la prévention et le contrôle de l'infection, la communication du risque et l'engagement communautaire. Également, la mobilisation des partenaires pour pouvoir réellement ensemble supporter les pays à réduire cette maladie. Il faut également dire que actuellement, beaucoup de pays font des efforts dans le financement de cette lutte, notamment avec la conversion des fonds COVID pour pouvoir réellement faire du pick-up pour alors rattraper les enfants. Et ça, c'est véritablement encouragé dans la région. Mesdames, Messieurs, chers participants, sur le plan épidémiologique, il faut dire que tout en vous souhaitant une très bonne participation, on souhaite qu'il y ait des questions et on pourra répondre. Nous attendons donc une grande participation. On est sûr qu'il y aura une très bonne facilitation et surtout, nous souhaitons que ces formations puissent être relayées, que vous puissiez faire des formations en cascade jusqu'au niveau des formations sanitaires, même celles qui ne sont pas encore concernées parce qu'il y a une extension et le risque demeure, ou alors que vous puissiez partager les modules ou alors les documents de référence que nous allons vous donner à la fin de ce webinaire. C'est sur cette note d'espoir que je déclare ouvert ce webinaire sur la réponse de l'épidémie contre la diphtérie dans la région africaine de l'OMS. Je vous remercie pour votre aimable attention.
So thank you so much, Professor Bita, for those opening remarks and really setting the tone for this webinar. Thank you for taking us through the epidemiology of what we have currently within the African region. Many thanks. So we'll just go through the housekeeping rules, and you can see the agenda, things that we will do. To ensure we have a smooth session, I'll be taking us through the following instructions for us. Kindly use the Q&A feature for questions regarding the topic and presentations. Kindly note that only questions in the Q&A will be answered during the sessions. Live questions will be taken at the end of all presentations. Use the chat feature that you have on the left here for questions regarding to IT or logistics. So there's interpretation, concurrent interpretation for this session in English, French, and Portuguese, which is available by clicking the interpretation button. Click on interpretation and choose the language that you would like to hear. To hear the interpreted language only, click mute original audio. As you can see down here. And kindly note that interpretation of proceedings serves to facilitate communication and does not constitute an authentic or verbatim record of the proceedings. So only the original speech is authentic. There is live transcription available. So click on show captions and the caption would appear on the screen. To close the caption, click hide captions. So recordings, materials, and feedback. This session is being recorded and we take your attendance as consent to be recorded. Recordings will be shared after the session in English, French, and Portuguese. Session materials, including session recordings, will be emailed to participants in the days following the webinar. So as we continue to improve our training programs, your feedback is invaluable to us. A survey will be shared at the end of this session. And we highly encourage you to share your thoughts and suggestions. Your input will help us to tailor further sessions to better meet your needs and expectations. Furthermore, during the questions and answers, our Portuguese speakers are to raise their hands, so you'll be given priority. Because if you type in the chat, we may not be able to translate it. So your Portuguese speakers will be given priority to ask their questions live during the question and answer session. Thank you, colleagues, and I'll hand over to our first speaker. Our first speaker is Ms. Eme Ekeng from the Nigeria Center for Disease and Control and Prevention to take us through the laboratory aspects in responding to diphtheria. Eme, over to you.
Good morning, everyone. Good morning, colleagues. Please, can someone confirm if you can hear me?
Yes, we can hear you loud and clear.
Okay, so my name is Eme Ekeng, and I'm a medical laboratory scientist. I work with the Nigeria Center for Disease Control National Reference Laboratory, and I currently act as the NCDC Technical Working Group Diphtheria Laboratory Pillar Lead. And with me in this session is the Director of Public Health Laboratory Services, NCDC, Mrs. Olajumoke Babatunde, who will be supporting me in this session. So I would like to talk on how we build capacity for diphtheria in an outbreak setting in Nigeria. So this is an outline of this session. I'll start with how we started and the laboratory response activities during the outbreak, the laboratory findings, samples collected, and the laboratory results. I'll also talk on the achievements, challenges, and the lessons learned from the outbreak and next steps. So before March 2020, there was no capacity to test for diphtheria in the NCDC laboratory network. So in March 2020, our colleagues from UK HSA organized a workshop on laboratory diagnosis of diphtheria using culture, ELEC, and real-time PCR. 5 laboratories were selected and 8 scientists from these laboratories were nominated for this training in March 2020. After this training, all the laboratories that were trained were enrolled in a diphtheria external quality assessment program organized by the UK NEQAS. Fast forward to later 2020, the Lagos University Teaching Hospital, which was one of the laboratories trained in March 2020, identified 2 diphtheria cases and sent this presumptive isolates to National Reference Laboratory for confirmation. At the National Reference Laboratory, that's the NRL, we confirmed these 2 isolates as positive for Corynebacterium diphtheria bivalve gravis. We then sent this isolates to the UK HSA laboratory in Colindale for further characterization using multilocal sequence typing. And fast forward to October 2020, the UK HSA organized a virtual training for laboratorians, surveillance officers, and clinicians on laboratory diagnosis of diphtheria. And after this virtual training, 3 laboratory scientists were nominated to attend a training of trainers program in UK HSA Colindale on laboratory diagnosis of Corynebacterium diphtheria. After this training in October 2020, we organized a step-down training in January 2023 for 12 laboratories and some scientists from these laboratories on what we learned in October 2022. So some of these key laboratory response activities we had to this outbreak, we built capacity for state laboratory officials and national laboratory officials on sample management, that is sample collection, packaging, and shipment to the laboratories. And we also trained laboratory scientists on diagnosis of diphtheria. We also carried out assessments because our aim was to expand the laboratory network for diphtheria. So we assessed laboratories that had the potential to test for diphtheria and optimize the labs that passed these assessments. We carried out preliminary culture in the state level and confirmatory testing in the national reference laboratories. We also distributed laboratory items like sample collection materials and diphtheria reagents across the testing labs and affected states. Other laboratory response activities included remote and on-site technical support to laboratorians at the subnational level. We leveraged on the National Rapid Response Team deployed to the affected states, and part of the team members were laboratory officials. So we used this opportunity to liaise with the state laboratory focal persons. We mentored them on coordinating response activities, coordinating sample collection, sample packaging, sample transport to the testing laboratories or national reference laboratories. We also supported in data reporting for laboratory data in the subnational level. We also engaged with partners and stakeholders to support strengthening diphtheria laboratory capacity, like the MSF, WHO, UK HSA, UNICEF, on how to support these laboratories in testing for diphtheria and also sample management. We gave weekly updates to the National Technical Working Group on our current activities, our challenges, and next steps. We also carried out confirmation using ELEC PCR and also API when available on this suspected isolates and clinical samples, and also received reagents at the NRL, and we also plan on distributing reagents to the trained sites. We then enrolled these laboratories that had capacity to test for diphtheria for the UK NEQAS External Quality Assurance Program. So like I mentioned earlier, we carried out assessments to some of these laboratories in the affected states, and these were our major findings. We noticed that the major strengths in most of these laboratories, they had the capacity to test for basic routine microbiology culture, that is microscopy culture and sensitivity testing. They also had equipment available for culture like incubators, autoclaves, and microscopes. However, some major gaps we observed were most of these laboratories lacked biosafety cabinets to carry out testing, and this was a major prerequisite for diphtheria testing. We also observed that we had a low number of laboratorians that had the knowledge of diphtheria laboratory diagnosis, and the labs also lacked diphtheria-specific reagents, which included whole cellulite medium, ELEC, and PCR reagents for testing. And most of this staff were not vaccinated for diphtheria. After these major findings, the NCDC was able to support some of these laboratories through capacity building and training the laboratory personnel on diphtheria diagnosis. We also supported sample shipments and referrals from the state hubs, that's the treatment centers, to the state testing laboratories, and also to the national reference laboratories. We also carried out equipment installations. We repaired obsolete equipment. We certified the biosafety cabinets that were obsolete in the laboratories. We also calibrated equipment in line with the relevant standards. We developed and disseminated guidelines for diphtheria laboratory diagnosis, SOPs, job aids, and the national test algorithms to the testing sites and also to the affected sites. We supported basic implementation of quality management systems, like supporting these testing sites with control strains for testing of diphtheria, and also enrolling them in support of the UK HSA for the diphtheria external quality assessment to test the proficiency of these laboratories. Like I mentioned earlier, we also gave reagents and consumables, and also sites that lacked the biosafety cabinet but had the potential to test for diphtheria. The NCDC supported them with biosafety cabinets, refrigerators, and incubators. So this is an overview of our diphtheria national testing algorithm in Nigeria. Our priority samples are nasopharyngeal and oropharyngeal swabs to be transported in Amy's transport medium or Caribbean medium at 4 degrees centigrade within 24 hours to the testing laboratories. At the testing laboratories, the recommended medium are blood agar, Hull cellulite, and Hinsdale, but most of the laboratories just had blood agar to test for diphtheria. And after incubating, the laboratories were to gram stain these isolates and notify the NRL if they see suspected gram-positive rods in Chinese letters. And then, yes, they were also expected to carry out biochemical testing according to what they had available in the laboratories. Presumptive isolates were sent to the National Reference Laboratory for confirmation. And at the National Reference Laboratory, we carried out identification tests using either real-time PCR, API, and then we carried out the ELEC toxin producing test and AST, that is antimicrobial susceptibility testing for the confirmed diphtheria isolates. We've also sent some of these isolates to the genomics unit for sequencing to understand the dynamics of the outbreak. So this is a consort diagram summarizing our laboratory activities from the onset of the outbreak. We received over 19,000, we had over 19,000 suspected cases in the country as at November 2023, and we were able to collect 6,289 samples from these suspected cases. 2,680 samples were shipped to the NRL, which includes clinical samples from states that didn't have the capacity to test for diphtheria, and isolates from the testing laboratories at the subnational level. We cultured these at the NRL and were able to get 675 presumptive isolates of diphtheria and subjected them to identification tests using either API, PCR, or conventional method when this API and PCR reagents were not available. We were able to confirm 373 Corynebacterium diphtheria isolates and subjected them to toxin tests. And all of these isolates were positive for toxin producing diphtheria. We also subjected 214 of these confirmed isolates to AST testing, and we have 159 isolates awaiting the next batch of AST testing. We've sent 110 of these confirmed isolates to the genomics unit for sequencing. So this is a chart showing the distribution of the clinical samples and isolates sent to the NRL by the states. And we have received samples from 35 states out of 36 plus the FCT at the NRL. This is another chart showing the distribution of laboratory confirmed samples by the states from EpiWeek 46 to EpiWeek 48, 2023. And from this chart, we can see that most of the laboratory confirmed cases were from Kano, Borno, Yobe, and Katsina, respectively. This is a chart showing a weekly distribution of samples by EpiWeek from EpiWeek 46, 2022 to EpiWeek 48, 2023. And from this chart, you can see that most of these samples received were in EpiWeeks 43, 42, and 46, 2023. And this shows the turnaround time of National Reference Laboratory in releasing the laboratory results. So we were able to meet up with the target of 80% of test results within 7 days of receiving the samples in the laboratory. And we actually carried out AST testing for 214 samples, and this is the result of the AST analysis. So from this, we can see that over 80% of these isolates were sensitive to erythromycin and tetracycline, and most of the isolates were resistant to trimethoprim sulfamethoxazole, cefotaxime, benzylpenicillin, and ciprofloxacin. They were either resistant or intermediate. So our key achievements from this outbreak: we started with just 5 laboratories at the onset of the outbreak, and now we've been able to optimize 15 additional laboratories. So we have in total 20 laboratories in the NCDC Diphtheria Laboratory Network. We've also been able to confirm over 300 isolates of Corynebacterium diphtheria at the NRL. We've trained laboratory personnel on PCR testing on clinical samples. This training occurred in Cyprus, organized by our colleagues in UK HSA. And right now, we are actually having discussions on optimizing PCR on clinical samples instead of isolates. We were also able to continue testing amidst limited laboratory resources. For example, our laboratories at the subnational level initially lacked diphtheria-specific reagents to test. So they were able to use the basic culture reagents to test for diphtheria. We've also commenced whole genome sequencing on the Corynebacterium isolate, as mentioned in my previous slide. In this outbreak, we actually faced challenges, and some of these key challenges include inadequate knowledge of sample collection at the onset of the outbreak, because this is like the first diphtheria outbreak in NCDC. So we actually had a low number of people that had knowledge to collect samples for diphtheria testing. We also faced the challenge of using inadequate transport medium in shipping these samples, because the priority samples were nasopharyngeal and oropharyngeal swabs. So automatically, the states were using VTMs to send the samples initially. But after disseminating the SOPs and the job aids for sample collections, we had a marked improvement in this. We also, and we're still facing the low test positivity rates for these samples. And we actually facing limited supply of sample collection materials, consumables, and diphtheria-specific reagents at the subnational level. From this outbreak, some of the lessons learned were the importance of laboratory readiness and capacity to respond to the outbreak. Thankfully, we'd like to use this medium to appreciate our colleagues from the UK HSA and other partners for their proactiveness in making the country ready, because this training happened before the onset of the outbreak. So we actually saw the importance of training laboratory scientists on diagnosing diseases that may likely occur. We also saw the importance of making resources for laboratory diagnosis available, prepositioning these laboratory reagents and sample collection materials across the testing sites to prepare themselves for any outbreak. We also saw the importance of partnership and collaboration, partnership with WHO, partnership with MSF, with US CDC, with UK HSA, and other partners in strengthening laboratory capacity in the country. We also saw the need of validating new protocols beyond the norm, because we were trained on testing on isolates instead of clinical samples. And because of this isolates, we actually faced low positivity rates. So we've seen the need to also validate new protocols like PCR on clinical samples directly instead of isolates to improve the positivity rates. We've also seen the importance of documenting events to help improve our guidelines, protocols like pictures and case details, because this is the first of its kind in NCDC. So we've seen that need to document events to help us improve our testing. So our next steps is to finalize guidelines on laboratory diagnosis of diphtheria. We also intend to carry out whole genome sequencing for confirmed isolates, which is actually ongoing, and we are analyzing the results. We are also optimizing protocols for PCR on clinical samples and metagenomics, and we intend to scale up the diphtheria network by accessing more laboratories and optimizing more laboratories in the country. We've also planned on building capacity for more laboratories in diagnosing and diphtheria, and support the sites with reagents and consumables to improve testing. We also intend to document possible non-toxigenic toxin-producing Corynebacterium diphtheria strains. So I'd like to acknowledge my organization, NCDC, the UK HSA, MSF, WHO, the Diphtheria Laboratory Network, the US CDC, AFRINET, and UNICEF for their constant support. Thank you, and over.
Great. Thank you so much, Ene, for sharing this wonderful experience with colleagues, learning from what Nigeria has done in testing this. And we've seen the importance of partnerships in driving this response to this level. We know that we'll move much further. So colleagues, from this presentation, kindly type your questions in the Q&A chat so that colleagues can start responding to the Q&A chat. We have a short time for this webinar, so let's use this opportunity to type in the Q&A chat, and there'll be responses typed out there. So thank you. We move to the next presentation quickly, which will be on vaccination. And Dr. Sheila will be the one taking us through the things we need to know about the vaccination within this response. Over to you, Dr. Sheila.
Good morning, everybody. I'm going to quickly share an overview of diphtheria immunization. I'll touch on the response activities to diphtheria outbreaks, and also, most importantly, how to close immunity gaps in the long and short term with catch-up immunization activities. So briefly, the diphtheria vaccine is a bacteriotoxoid. It's an inactivated toxin, and it's administered as a 3-dose primary vaccination schedule beginning at 6 weeks. WHO also recommends booster doses, which are needed for longer-term protection, and these are given. The first is recommended to be given in the second year of life, 12 to 23 months, then 4 to 7 years, and 9 to 15 years of age. The diphtheria vaccine is effective in preventing diphtheria-related deaths, and its estimated effectiveness is between 70 and 90% effectiveness. Higher dose of diphtheria toxoid is given to children below 7 years, whereas adolescents and adults usually received a reduced dose of the toxoid, and this is to reduce reactogenicity. And the vaccine is always given in combination, generally or commonly with tetanus toxoid and pertussis, wholesale or acellular pertussis. And listed below are the different combinations that are available and that we are currently using in our different countries. So WHO recommends for routine schedules, the primary series, as I already mentioned, 3 doses. The first dose usually given at 6 weeks of age, the second dose given 4 weeks after the first dose, and the third dose given 4 weeks after the second dose. And this should be given within the first 6 months of life. For booster doses, as I already mentioned, there are also 3 as indicated. However, for non-routine vaccination or immunization, when we encounter previously unimmunized individuals above 1 year of age, the recommended primary series is still 3 doses, the first given at the first point of contact, the second dose is given 4 weeks after the first dose, and the third dose is given at least 6 months after the second dose. And a further 2 booster doses are recommended with a minimum interval of 1 year between the 2 doses. And as I already mentioned, still, DPT or the combinations with a higher dose of diphtheria, which is the capital D, are recommended for children below 4 years, and the combinations with less toxoid are recommended for older children, adolescents, and adults. Usually we use TD, D with a small capital D from 4 years and above. And in the African region, the commonest combination that we are currently using in most countries is the penta, that is DPT with wholesale pertussis, Haemophilus influenza type B, and Hep B. And as you can see, most countries are using the schedule starting at 6 weeks, 10 weeks, and then 14 weeks for the primary series. And this is in 34 countries. The rest of the countries, it is country specific, and these are the different different schedules or variations in schedules that are used in the different countries and combinations of vaccine. For booster doses, we have only 9 countries in the African region that are currently providing boosters, and most of these are non-Gavi countries or non-Gavi eligible countries, but would wish that more Gavi eligible countries also include boosters in their schedules. Over the past 22 years, for DPT1 and DPT3 coverage, this has been the trend. Currently in 2022, according to WENIC, the coverage for DPT1 was around 73%, and then that coverage for DPT1 at 80%. This is still not very optimal, but the coverage has not been increasing much it had peaked a bit in 2019, and we wish to go back to 2019, but further also improve the coverage for DPT1 and DPT3. Still in the African region, these are the countries listed in the table on my right, are countries with coverage for DPT3 below 80%. Coverage of between 80 and 85% is needed to reduce the threat of outbreaks, according to the WHO position paper for 2017. And these countries, about 22 countries in the African region, have coverages below 80%. So we still have work to do to improve coverages and reduce the risk of experiencing these outbreaks, especially diphtheria outbreaks in our countries. Nigeria and Guinea are highlighted in red because these already have ongoing outbreaks, but we have other countries, Mauritania, Nigeria, that are also currently experiencing outbreaks for diphtheria. When it comes to the vaccination response to the diphtheria outbreak, the goal is really to rapidly raise population level immunity and reduce the number of susceptible individuals to reduce transmission and control the disease outbreak. For the diphtheria outbreak campaigns, normally we conduct selective campaigns targeting close contacts and other at-risk groups, usually health workers, high-risk groups, and other outbreak response workers, and these should be considered in when we are responding to should be considered for vaccination when we are responding to the diphtheria outbreak. And also efforts should be made to catch up on individuals who are not fully immunized or under-immunized against diphtheria in a multi-pronged strategy. And then the vaccination strategies, of course, have to be based on the epidemiology of the disease. These are some of the considerations when preparing or planning to conduct vaccination response activities, considering the age-appropriate formulations of the vaccine. As I mentioned, the DPT, or the one with the higher dose of the toxoid, is usually for children below 7 years, and then the one with a lower concentration of the toxoid is used for children from 4 years and above. And so some of these considerations will be informed by the availability of the vaccines, the epidemiology, and other factors surrounding the outbreak. Then the timing of the intervention, when we start the vaccination response, this also has to be considered. Then the target age group, still based on the epidemiology, which age groups are mostly affected, but also considering the age cohorts, especially those that have missed their routine immunizations, or those that are unvaccinated or under-vaccinated, and then susceptibility of the profile of the population, and other key considerations as informed by the epidemiology. The vaccination response approaches also have to, should be guided by epidemiology and what the target for vaccination really is. You can use fixed sites, mobile teams, door-to-door approaches. These are not very different from other campaigns that we conduct, but these again should be informed by available resources and also the epidemiology. And during planning, we need to determine how many campaigns need to be conducted, the interval between the campaigns, the geographical scope, the target group, and the resources available to be able to close the immunity gap. We also have to have very good plans, and which are costed, but importantly, we need to advocate for high-level commitment to be able to support the campaigns with resource mobilization, with coordination, and generally implementation of the response. Then micro-planning and logistics, preparing adequately for the campaigns before you conduct the campaigns, because you need to be able to implement effective campaigns, conducting trainings, advocacy, social mobilization and communication, AFI monitoring and preparing for crisis communication, pre-campaign supervision and monitoring, and campaign readiness assessment. These are very critical in ensuring that we effectively utilize available resources, because once we are not adequately prepared for the campaigns and we just go in, most likely will not have an effective campaign, and the immunity gaps will still persist. So to have an effective campaign and avoid going back for mop-up activities or having an ineffective campaign, we need to prepare adequately. Much as it's an outbreak setting, it's an emergency, but preparation is very key. And then in implementation, supervision is very key to make sure that the campaign is being implemented correctly, but also the post-campaign activities are important in reviewing what was done during the campaign, what could possibly be improved, because in most cases we are implementing these campaigns in phases. So reviewing, conducting post-campaign review meetings, coverage surveys whenever possible, and to inform subsequent activities, but also if there is need, conducting mop-up activities to make sure that we are achieving good coverage during these campaigns. Then, most importantly, diphtheria vaccination response activities also provide us an opportunity to emphasize catch-up vaccination. Diphtheria vaccination response in itself is of unvaccinated or under-vaccinated individuals, but it also offers an opportunity to catch up on vaccination for other antigens besides diphtheria. And catch-up vaccination itself is vaccinating any individual who is missing doses or who is eligible per national immunization schedule. And this should be an essential and ongoing part of all immunization programs. For catch-up activities, we need to take any opportunity to provide and complete the primary series of 3 doses of diphtheria-containing vaccines for those who have missed or have not completed their immunization schedule, and then using the outbreak activities to catch up on all the other missed antigens. Currently, we have the big catch-up, which is like an intensification of catch-up activities. It has a 3-pronged approach. It's an essential immunization and recovery plan for 2023 and beyond. And in this 3-pronged approach, the aim is to catch up on missed children, reaching all children that missed vaccination during the pandemic period, but also including those that were missed or the 0-dose children and under-immunized children in 2019. So we have a number of cohorts of children that missed their vaccinations between 2019 and 2023, and we need to catch up on all these children that have missed their vaccinations to close the accumulated immunity gaps. And then restore immunization programs. We need to restore, as I showed during the trends, the coverage for DPT had slightly peaked in 2019. We need to at least go back to the 2019 coverage levels, but most importantly, keep improving the coverage for DPT and even other antigens. Then strengthen immunization programs within the broader primary health care to improve resilience and resume trajectory to the IA 2030 goals. Importantly, each country needs to have a tailored response, and also we need to make sure that we are implementing not just the short-term, but also the long-term solutions. Recently, the Regional Immunization Technical Advisory Group sat in November, and some of the recommendations, they strongly recommended that all countries should revise their policies for catch-up to expand the immunization age ranges to below 5 years. We've seen that during the pandemic phase, we had many cohorts of children that missed out on vaccination that we need to catch up on. And many countries have restrictive policies that are limited to up to 2 years. But we need countries to be able to expand their policies and to revise their policies and expand this immunization age range, but also to be able to institutionalize catch-up activities as part of ongoing immunization programs. So countries need to include catch-up activities in their costed national immunization strategic plans and vaccine forecasting. This should be part of ongoing immunization activities and not just a one-off activity or a one-off campaign. So much as we have the big catch-up now, that is more of a short-term strategy, we need to continue or institutionalize catch-up activities in our immunization schedules. And these are some of the resources on catch-up vaccination, WHO recommendations and guidance. On the left, we have the guidance for planning and implementing catch-up vaccination. In the middle, we have the guidance on how to establish catch-up vaccination policy and schedule. And then on the right, we have the WHO recommendations for interrupted or delayed routine immunization. And these are key resources that we can utilize to improve the catch-up policies or modify the catch-up policies in our countries and schedules. So how do the big catch-up activities help to address diphtheria risks? In the short term, the big catch-up, there's intensification of activities through routine immunization, but also periodic intensification of routine immunization activities and enhanced outreaches. But these in the short term. And in the long term, we need to make sure that we have policies in place, but also schedules as part of our routine immunization activities, which the policies and schedules covering up to 5 years. And then also utilizing every opportunity for health visits and school and daycare vaccination checks to catch up on individuals that have missed any vaccinations. As a way forward, we encourage all countries to establish an optimal routine immunization schedule for diphtheria and encourage that countries' NITAGs to consider having boosters in their immunization schedules, those that have no booster doses and also those that have less than the recommended 3 boosters. Then importantly, to mainstream catch-up vaccination as part of essential immunization activities with catch-up vaccination policies in place. And this is for the long term and make sure that we are closing these immunity gaps. Then establishing optimal national and subnational capacity for preparedness and response to diphtheria outbreaks and strengthening reporting of diphtheria through case-based surveillance and other reporting mechanisms. And then achieving and sustaining 0 deaths to diphtheria in the region by 2030. Lastly, we have, this is for your information as well, we have another webinar on big catch-up implementation right after this webinar. For those who are interested, there will be updates and overview of the big catch-up and also updates from Gavi on the support to the big catch-up and how to refine those requests and monitor catch-up activities. We hope to see you there as well. Thank you.
Thank you so much, Dr. Sheila, for the presentation. Thank you for taking us through that. We've seen that colleagues have been putting in questions in the Q&A chat, and experts have been responding to those questions and answers. To the questions and providing the necessary answers. So we just have a short pause. Is there any Portuguese speaking person that want to ask a question? Kindly raise your hands. We give priority to the Portuguese colleagues. Other colleagues, to maximize time, we may just need to put it in the chat so that the responses can be put in there. Okay, I see a hand up. Okay, Sylvester. Can you unmute your mic? IT, could you assist? Sylvester, can you unmute your mic? Okay, seems you're having challenges in Sylvester coming up with questions, but several of the questions that have been put in the chat has been answered in terms of case definition. WHO case definition is used, and there are different classifications for categorizing the cases, whether it's clinically confirmed, laboratory, or epidemiologically linked. Colleagues have asked about whether biosafety cabinets have been used, and that has been answered. Other questions have been on, is this current outbreak linked to low coverages? And I think Dr. Sheila has talked about that, and that's why we have this big catch-up. Once the coverage is low, then communities are susceptible to having diphtheria. And she also emphasized on the need for booster doses, which is really important to improve the vaccination, the immunity of persons who take it. So a single dose doesn't work. You need to have the scheduled doses, and once it's complete and you have the booster doses, then we have our communities covered. Professor Bita has also talked about definition of an outbreak. You just have one case, then an outbreak can be declared. So we need to be very proactive. It's just a little fire that will make the whole forest to be burned down. So once our surveillance is sensitive and we pick them, then we respond appropriately. Okay, so since there's no hand raised, we will move on with the next presentation. Our colleagues will continue to give responses in the Q&A chat. So we'll move to the next presenter, and that would be on case management, Dr. Salam. Could kindly now share your screen.
Good morning, everyone. Let me share my screen. So for the good morning, this morning I'll be speaking about a case presentation with regards to complications that we see at the Diphtheria Treatment Center from Kano. My name is Dr. Salma Adeswait. I am a consultant pediatrician and Kano State Case Management for Diphtheria Outbreak Response. So as a form of introduction, in the DTC, we have observed 5 complications and which attribute to the high mortality and long morbidity in the of diphtheric patient. The identified complications are AKI, thrombocytopenia, myocarditis, acute respiratory distress, polyneuropathy in descending order, with AKI having the highest cases that we are seeing and have the highest mortality, while polyneuropathy has the least, with the least mortality. Now, this is just a picture tour of our center. This is the triage area. That was our center is set up by MSF. So they gave us all the facilities that we needed in terms of the capacity building and training of staff, equipment and consumables are all given by MSF. So in the triage is where the patient placement is done. Now, based on the identified complications that we've been managing, we have we've partitioned our wards into the AKI ward, we have the thrombocytopenic ward, we have myocarditis ward, and we keep this patient on close check with any patient that has a derangement in the UNE at the critical sample stage. When during the critical sampling during the triage is placed on the watch list so I'm placed in the AKI ward for further evaluation and monitoring. So this is a thrombocytopenic ward. Then this is the recovery unit. This from here, any patient that has recovered will be observed for some days before he or she is discharged for follow-up. Now this is our ICU ward for management of complications. So now my case scenario this morning, I'm presenting a 7-year-old boy from a rural settlement who presented with fever, sore throat, difficulty in swallowing, swollen neck, and change in voice for 6 days. He had a history of contact with a suspected heat case. He is not vaccinated at all. Examination reveals a thick nasopharyngeal pseudomembrane. Throat swabs were taken. Blood were taken for EUCR, full blood count, random blood sugar, malaria parasite were all done. His weight on admission was 16 kg. Patient was placed on DAX, ceftriaxone, hydrocortisone, paracetamol, IV azithromycin, hydrogen peroxide gargle, and also NG tube feeding. On D1 of the admission, patient was noticed to be moderately pale. PCB was 18%, full blood count revealed platelets of 82,000. So a diagnosis of severe diphtheria with asymptomatic thrombocytopenia was made. Fresh whole blood and platelets were transfused. Day 6 of admission, he was noticed to have decreased urine output with facial puffiness. He made a urine output of 380 mils in 24 hours. Urea was 15, creatinine was 153 millimoles per liter. Patient was rehydrated by orally using ORS and was also given furosemide, and to monitor the strict input and output of the patient. And the plan was to repeat a UNE and creatinine in 24 hours. On day 7, patient was noticed to have developed mild respiratory distress. With heart rate, it was bradycardic, 72 beats per minute. We requested for ECG. Full blood count was also to be requested to be repeated. A diagnosis of severe diphtheria complicated by thrombocytopenia and bradycardia was made. He was placed on oxygen. IV fluid was given, normal saline, and atropine was also added to the management at a dose of 0.03 milligram per kg per dose, and to keep the patient hydrated. We also noticed that the edema has increased. On day 8, his pulse rate was 86 beats per minute, regular volume. Blood pressure was 90/60 millimeter mercury. EUCR result revealed urea of 18.3, creatinine of 231. So assessment of severe diphtheria and AKI was still entertained. Plan was to continue kidney challenge and to monitor input and output and to continue other management. On day 11, patient was noticed to be weak. He has made 475 mils in 24 hours. So there's an improvement in the urine output of the patient. On examination, he was found to be lethargic, mildly pale. Respiratory rate was 68 beats per minute. It was weak, thready pulse. BP was 60/40. He was hypotensive with a capillary refill pressure of 5 seconds. Electrolytes were normal. An assessment of cardiogenic shock was made. Shock was corrected and patient was placed on dopamine infusion. Few hours later, patient was noticed to have developed carpopedal spasms. There was an improvement in the pulse rate, now has risen to 94 beats per minute. Blood pressure has appreciated to 18/50 millimeter mercury. We requested serum calcium, which the result came out and shows a calcium of 6.1, potassium of 3.1. So he was hypocalcemic. Patient was given calcium gluconate, and IV fluids and dopamine infusion were continued. Day 12, he was moderately pale and in respiratory distress, has vomited severally. On examination, he has appreciable pulse rate of 104 beats per minute, blood pressure 75/45, has an S1, S2, and he was tachypneic 40 cycles per minute. SpO2 is hypoxic 89% on room air. Chest was congested with widespread crepitation. So assessment of aspiration pneumonitis plus myocarditis was made. Patient was placed on oxygen and was transfused accordingly. Metronidazole in view of the aspiration where he was added, and also he was given an antiemetic, ondansetron. 13 days to admission, patient still was on oxygen. HB results reveal 7 gram per DL. Platelets have appreciated to 110,000 count. On examination, blood pressure was 78/45 millimeter mercury. Heart rate was 98 beats per minute. He had an enlarged tender liver, which is 6 centimeters below the right costal margin. The plan was to transfuse with fresh whole blood and to continue monitoring and continue other medication. On day 14, the UNE results revealed hypokalemia, potassium of 2.5, creatinine was normal, serum calcium still was low, platelets normal. So repeat EUCR was the EUCR done in terms of the urea and creatinine were normal, and he was making adequate urine. Echo result was out and it shows an irregular septal motion seen with fair left ventricular function with normal size heart chambers. Potassium and calcium were corrected and patient was placed on maintenance supplementation. On day 22, patient was discharged as he has made remarkable improvement in his general condition of patient, but has lost weight. His weighs now 15 kg, has lost about 3 kg. He was to be followed up on weekly basis up to 6 weeks and to receive booster vaccination at 3 weeks post-discharge, and was referred to nutritional clinic at the ITFC center. So this is the patient on a discharge. He is very frail and has lost significant weight on admission, but he was hemodynamically stable. And so he can walk. He has been weaned off most of the thing, and he's only going home on nutritional rehabilitation. On follow-up 2 weeks after discharge, patient presented again with complaints of cough, regurgitation from the nose, fever, inabilities to stand still, and not tolerating oral fluids for 1 week. Examination reveals again another pseudomembrane on the tonsils. Weight was 12.8 kg, has lost further 3.2 kg from admission, from discharge. Patient was wasted. Respiratory rate was 38 cycles per minute. SpO2 was 88% on room air. He had widespread crepitation. Investigation, we requested for TB screening. TB screening was negative. Potassium 2.3, and first full blood count reveals leukocytosis. Assessment of diphtheria reinfection with complication, aspiration pneumonitis, severe malnutrition, dyselectronemia, and neuropathy was made. Patient was placed on oxygen, antibiotics, intravenous fluid. Potassium was corrected, was also added prednisolone. Resomal was given for rehydration, and was also placed on NG2 feeding. He spent 13 days on admission and he made steady improvement. He was discharged further again to the ITFC for continuing nutritional unit rehabilitation and to be followed up in specialty neurology clinic for neuropathy as well. So 2 weeks after discharge, he has remained stable and weighs 18.5 kg. He came on follow-up and was vaccinated, and he was to continue also with relevant follow-up visits. The patient presented with 4 complications: AKI, myocarditis, thrombocytopenia, neutropenia, neuropathy, in addition to hypocalcemia, dyselectronemia, and also malnutrition. Most patients presenting, as we observe, with 2 or more of these complications die in the center. And also, it was a case of reinfection, which is, we have been seeing quite a number of them coming back with reinfection 2 to 3 weeks, sometimes up to 4 weeks after the initial infection of diphtheria. So in conclusion, diphtheria is a multisystemic disease that leads to fast deterioration of organ system. And so there is need for doctors to be on high alert and pay special attention to identify organ systems that are usually affected. Abnormalities, once detected, should be managed in a multidisciplinary approach, and diphtheria can present with other comorbidities, and so there is need for a holistic approach in management of diphtheric patients. This is the patient on follow-up. He has gained significant weight and is now even back to school with no other complication. Thank you very much.
Oh, excellent. Thank you so much, Dr. Salma, for really taking us through that live scenario. It really shows how case management really goes and the intensity and the resources that are needed to get someone out. It's really time consuming. You need the human resource, you need the necessary facilities needed, other aspects in the contact tracing, the case contact management that needs to be done, follow-up. So it's just, we see that prevention is actually better than cure. But once we have a case, yes, no case should die, and things can still be done to do that. We really thank you for this splendid exposition you've taken us through. Many thanks. So colleagues, you can put in your questions in the Q&A chat. Dr. Salma is available to respond to the questions. So thank you for doing so well with time. Really appreciate it. We move to the next presentation, which is on infection prevention and control. And that will be taken by Dr. Deborah Barasa. Over to you, Deborah.
Okay, so thank you very much. I will be taking you through the infection prevention and control for diphtheria. Okay, so my presentation outline is as follows. We'll talk about diphtheria transmission cycle, the importance of IPC, the minimum IPC standards at healthcare facility, and the IPC at household and community level, as well as the rapid assessment tool for respiratory pathogens. So I think Dr. Salma and colleagues have talked about the diphtheria microorganism, and it's really, diphtheria is an infectious disease caused by the gram-positive Bacillus bacteria diphtheria. And I think the laboratory colleagues will tell us the word corynea comes from the club, and the diphtheria is the leather or the pseudomembrane that is manifest during infection. So we've talked extensively about the respiratory manifestations of diphtheria. And as we have said clearly, it may present as a cough, sneezing, or any upper respiratory tract involving the nasal, the pharyngeal, laryngeal, the tonsillar region. So those are the symptoms which are really critical for us as IPC specialists. Again, another manifestation is a cutaneous and mucocutaneous manifestation, which at times we may fail to talk about. So one may present with a wound and This may have exudates, and these exudates can also be transmit infections. Equally, mucocutaneous manifestations, though rare, one may present with conjunctivitis or also inflammation in the genitourinary or pseudomembrane in the genitourinary system. And so we need to be observant about that, as well as adhere to IPC measures when in contact with such areas. And again, asymptomatic carriage, which may also propagate infections. So the chain of transmission, for an infection to spread, all links must be connected. And breaking any one link will stop the disease transmission. So what is this chain of transmission? We talk about first the infectious agent, which is the Corainae diphtheria. And following that, we have the reservoir. So the infection can reside in the mouth, the nose, the throat, and as we have said, cutaneous and mucocutaneous manifestations. So the disease can also reside in the infected wounds. And then there's a point of exit, which is through respiratory droplet from infected persons, as well as also infected wounds. And the mode of transmission can be direct and indirect. And like this, the respiratory droplets is mode of transmission can be through respiratory droplets or contact with the droplets, as well as a contact with the discharger. Maybe the soiled linen from patients through the wounds, and also the coughs and so on. And the point of entry is through the respiratory tract. And let us not forget the susceptible host. I think our immunization team talked so much about the unvaccinated, especially pediatric age group. And so for us to break this whole chain of transmission, then we need to ensure that we have IPC measures in place. And for the susceptible host, again, emphasizing the role of vaccination is really a critical pillar in terms of preventing propagation of disease during the outbreak. And also routine immunization is critical. So we'll go through the other areas where we as IPC play a role. So for IPC, we talk about standard and additional or transmission-based precautions. And for standard precautions, these are the bare minimum. You can see it's circular, blue at the center, and this is really the heartbeat of infection prevention and control. So whatever outbreak we are dealing with, whether it is diphtheria, cholera, Ebola, or even the nosocomial infections that we usually observe in the healthcare facility, standard precautions are really critical for IPC at any given time. And these include a risk assessment. So based on the risk, whether there'll be soiling, there'll be, contact with vomiters, etc. Risk assessment is critical whenever you're going to see a patient. Hand hygiene, again, is important because we know that microorganisms really can stay in our hands, and they can, and then transmission of infection from one patient to the other, or among health workers and even community, can occur. So hand hygiene is really a critical precaution for us as IPC. Again, respiratory hygiene, not only for the current diphtheria outbreak, but for any patient who comes in with upper respiratory tract infection, we need to ensure that respiratory hygiene is adhered to. You see, when we go to the facilities, we observe that we don't even have the posters for respiratory hygiene. So let us be advocates to ensure that we have hand hygiene, respiratory hygiene, posters, and also we are encouraging the multimodal approach. Again, patient placement for any infectious disease, any patient that you're suspecting the likelihood of infection transmission, we need to encourage that. And also for nosocomial infections. PPEs for whatever procedure that would require appropriate PPE usage, we need to strengthen that, and aseptic technique procedures. Again, safe injections and sharp injury prevention. We are working in a health care setting. We will always deal with injections. We need to fix IV lines. And also, as Dr. Salma has talked about, there's need for IV injections for these patients. The vaccination pill has talked about this. So safe injection practices are really critical, again, for diphtheria outbreak and also for others outbreaks. Environmental cleaning, as we said, contact precaution. We need to ensure that our environments are cleaned well using the appropriate disinfectants. So we go to facilities and we observe we are not cleaning, we're not disinfecting with the appropriate. For diphtheria, 0.1% should suffice. So even for diphtheria, not just cholera, but for any infection, we need to ensure that cleaning and disinfection is adhered to, and we'll go into details about that. Again, linen management, laundry and linen management is critical, as well as waste management. So infections, waste is being produced in the diphtheria treatment centers. We need to ensure that there's appropriate waste segregation, transportation, storage, and also that we are disposing appropriately. And decontamination and reprocessing of reusable patient care items is again critical for IPC. So standard is for whatever infection we are dealing with. And so even for diphtheria, we need to adhere to the standard precautions. Now, for transmission-based precautions, this is for the infection at hand. And since the diphtheria, as we have said, is respiratory droplet and contact precaution, so these are the precautions that we need to adhere to in addition to the standard precautions that we have. So patients who are suspects or confirmed diphtheria, we need to have isolation, and we need to have appropriate signages or posters when we're entering into the patient's room, so that health workers know what are the appropriate measures, IPC measures they need to adhere to before they enter, and then again the appropriate PPEs they need to wear. We also need dedicated materials and equipments for these patients. And if this is not possible, then cleaning between patients, possibly with 70% alcohol, like when we're using the stethoscope, is really important so that we avoid transmission of infection. Again, patient transport and movement, we tend to limit movement, but if this is necessary, then we need to have appropriate precautions, like patients should wear masks, and wounds should also be covered. Again, communication. So all these precautions, as we've talked about, we need to have a multimodal approach. We need to build it, like for hand hygiene. We need to have the right infrastructure. At times you go to diphtheria treatment center and you find that there is no water in this. So how are we telling health workers to wash their hands when we have no water? So we need to really encourage building it by having the appropriate infrastructure, appropriate maybe PPEs, disinfectants, IPC supplies and so on. And then we need to teach it. You go, and the attitude among health workers is that we were trained during COVID, but we need to have routine refresher training every 6 months to ensure that we are training general IPC as well as IPC for the disease at hand. Yeah, because at times you may find that people have been trained on general IPC, but when there's an outbreak like diphtheria, cholera, measles, and so on, then for the disease at hand, we need to train our health workers on that as well. And we need to monitor, we need to keep on checking and ensuring that IPC measures are adhered to, and we'll talk about a tool, and have the right have the right communication and reminders. So in this case, we need to see posters on hand hygiene, respiratory hygiene, patient placement, posters on signages on the right on transmission-based precautions, and so on. So these are lacking in many healthcare facilities, and maybe during this interaction, we will be able to see more so that our health workers are well informed on what IPC practices to adhere to, and then living it, the culture, having IPC champions, and ensuring that we have routine IPC practices. And I know we are out of COVID, so our health workers are a bit fatigued when we come to IPC measures, wearing masks and so on. I think that was observed in some of the countries. So we need to have that culture of improving IPC, because ultimately what that does is that health workers are exposed and infections rise, and then now they are unable to perform their duties, and the system becomes overwhelmed and might even collapse. Okay. So we talk about screening, triage, and isolation. This is very critical. When we go to facilities, it's important that at the entry to a facility, we have screening of patients on arrival. Yeah, we go to immunization areas for children. There is no screening that is taking place. We need to screen, and then for the presence of signs or symptoms of diphtheria, and then we place them in a dedicated area and implement transmission-based precaution as we are doing that. And upon placement, according to symptoms, we need to separate patients who have symptoms. So, you can get into a facility and you find children are there. Some of them have even swollen neck glands. Saliva is drooling out of their mouths. They have painful swallowing. You can obviously see from their facial expression, and they are mingling with other children in the facility, like, the HIV cases, the malnourished cases, and so on. So not just for the diphtheria, but any patient who has any symptoms of infectious disease, it's good to isolate, because we might amplify infections within the facility as well as in the community at large. So let us remember that critically as we go back to our facilities to strengthen screening and placing patients in a dedicated space who have symptoms and signs of the disease at hand. In this case, diphtheria, we anticipate upper respiratory tract infections, symptoms of URT, upper respiratory tract, and so we need to place them in a dedicated area. And equally, we need to cohort them if we are in an isolation area. So patients who meet the case definition, they can be cohorted in one area, and then also the staff. We need to have dedicated health workers who are interacting with patients in isolation center. That would prevent amplifying diseases within the facility or even outside of the facility. So let us remember to cohort the patients. So immediately we place the patients with upper respiratory tract infections, as we said, in a separate area. And then if suspected cases, then we admit to an isolation treatment facility, preferably a single room. If not, then we can cohort them. And even for the confirmed cases, then we are able to cohort the cases. And we need to keep the isolation area segregated from other patient care areas. We need to emphasize this. At times you go to a facility, you find that in the pediatric emergency unit, it is right next to the maybe the diphtheria treatment unit, and it's next to another to the maybe the pediatric outpatient, and they are using the same toilet, the same toilet and other ablution facilities. So you see this mingling. Even though you're saying you're segregating, they are sharing the toilet, and infections are likely to amplify, because this is the pediatric case is actually the cases of high preponderance, and maybe the immunity is not strong, they have not been vaccinated. So when we say isolating, we are really encouraging that we segregate and that they are not in contact with other patients, because you will find that a TB case now has diphtheria and they have HIV, and what are the likelihood of mortality in these cases? So let's ensure that, and let us observe 1 meter distance between patients. And the patient area needs to be well ventilated, and the disease is not contagious after completing 48 hours of antibiotics. So maybe focusing a bit on ventilation. I think one challenge we observe is that at times we close our windows and then we open the fans, and this would likely disperse microorganisms within the room that the patients are in. So what we are encouraging is natural ventilation. Observe 60 liters per second per patient airflow within the room, and if you have to place a fan, then it's better to place them close to the window, where it helps to move the air into the room. Okay, so the placement of the fan is critical. We are not saying we close the windows and then we open the fans, because now that one will just disperse microorganisms and increase amplification of disease. So contact and droplet precaution, this is like a signage that we have, which we are encouraging if you're working in the diphtheria treatment centers. Encourage your IPC focal point to have these signages at the entry of every diphtheria treatment center or every room. And what it's telling us is that for every health worker who gets into the room, they need to ensure that they have contact and droplet precaution, yeah? And also, and this includes having a hand hygiene, so they need to ensure that there's hand hygiene. So we need to have our hand hygiene stations there, and also with the right equipment like the alcohol-based hand rub, soap, and running water. So we may say we have hand hygiene, but we don't have it functioning appropriately. So we need to have that, and then have the appropriate PPEs. As we've said, what we're observing is maybe people are wearing masks, but they're not wearing the right gowns because of challenges like a lot of heat. And so we as IPC, we need to encourage the use of appropriate PPEs for our health workers while they're in contact with patients. Yeah. So the PPEs, as you can see, they are listed, and we'll go into further details. Again, good ventilation, we need to remind ourselves about that, and limit movements. If there's need for movement, we wear a mask. And cleaning and disinfection is critical at least twice a day. At times we meet support staff, they're not familiar with the concentrations of the disinfectants, how to clean, and so this needs to be trained. When we are training, we're not just training the health workers, but also the support staff, so that they can be able to improve practices. And I'm sorry, this slide is very busy, but it's just a summary of what we are saying. So for the patient, let's isolate them, let's separate them, let's limit movement, let's ensure there's 1 meter distance, and have them wear medical masks appropriately. And for family members, as you know, we are dealing with children, so maybe they will need a caregiver with them. So we need to educate the caregivers on hand hygiene, wearing medical masks, and also prophylactic antibiotics and vaccination for them. And also appropriate PPEs when they're within 1 meter distance. For health workers, hand hygiene is critical, wearing surgical masks and appropriate PPEs when they're within 1 meter distance. And also to use disposable or dedicated patient equipments, and refrain from touching their eyes, the mucous membrane, the nose and mouth, because during the procedures, because they're likely to contaminate themselves. And also avoid contaminating surfaces, the frequently touched surfaces. So when we say droplet precautions, when you're more than 1 meter, you can you may wear a mask, but since it's droplet, when you're within 1 meter, then a mask is important to wear, and other PPEs when you're performing procedures. And these include goggles or face shields, gowns, and gloves. Yeah, and this is for, as we said, contact and droplet precautions. So this is really a challenge in healthcare facilities, but we are encouraging that from this, you may talk to your colleagues and ensure appropriate PPEs are used. And also what we observe when we are looking at the throat, it's good to have the headlamp. At times we observe that health workers are removing their mobile phones and using the torches in their mobile phones and putting it back on the pocket. So already the phone is contaminated. So let us encourage the use of the lamps, the headlamps, when we are for viewing the throat for our health workers. Again, just a reminder, moments of hand hygiene. Let us have this poster, the 5 moments of hand hygiene. Before we touch, before any clean or aseptic procedure, we need to wash our hands. And after touching the patient, after touching the patient's surrounding, and also after body fluid exposure. This is again another important poster that we have, which we are not seeing in many facilities during this time. So posters on hand hygiene technique, let us remind ourselves, and let us also have the appropriate posters. And not just the posters, as we say, the multimodal strategy, building it, ensuring we have the appropriate infrastructure, teaching our health workers, including our support staff, the cleaners, the hygienists, checking it, monitoring hand hygiene, selling it, and that is through having posters and reminders and leaving it. So this is just not only for hand hygiene, but other precautions that we've talked about. Respiratory droplet, so wearing of masks. We need to see posters. We need to see that we have the appropriate PPEs at hand. We need to monitor that people are wearing PPEs and so on. So this is the isolation facility layout. And this is one, again, a challenge that we observe when we go to the diphtheria treatment centers. The layout is really a concern. So as we said, when patients come in for healthcare facility, it is good that we screen. We screen, and patients who that meet, that are suspected cases, then we need to, or cases who meet the case definition, then we need to place them so that they are not mingling with the other patients and increasing transmission. And then triage, I think Dr. Salma talked about that, triage within the healthcare facility. So for patients who meet the case definition, then they enter. They enter the isolation zone where IPC measures like physical distancing, 1 meter distance are observed and so on. And for the staff, as they enter, they put on the PPEs, and then they can go and review the patients within the diphtheria isolation center. Okay, and here is the patient exit. And we have a toilet dedicated to patients who meet the case definition. So you can see the toilet for case definition is very different from the non-suspect. But in most facilities, we are mixing both, and so infections are propagating and the whole area is contaminated or red. So let us ensure that the isolation layout is well adhered to. So for patients who don't meet the case, the non-suspected cases, now they are free to use any other healthcare facility within the facility that we are dealing with. So let us remember, we need to really separate these patients from the others because they are likely to amplify infections. So we normally encourage the use of a facility assessment tool. And this is conducted routinely, maybe daily, weekly, or monthly, depending on the score that a facility has. And why do we conduct assessment? It assesses the level of implementation of IPC measures. And whenever you have a suspected or confirmed case within a facility, it is important that you do routine assessments so that you ensure that you're gradually improving IPC practices and IPC measures within the facility. And this is done by trained assessors with competence in IPC. In Nigeria, we were able to use the LGA IPC facilitators. We can use that. And also you can use IPC focal points or anyone trained in IPC, so that we are gradually monitoring and ensuring we're improving our capacity. And also it's critical to say that once we have identified gaps, it's important that we improve it so that we are gradually improving the capacity. So it has multiple variables, as you can see. The program itself, it looks into the health worker, protection, the screening capacity, isolation capacity, hand hygiene stations, and PPEs that are used. Also looking into injection safety, environmental cleaning, decontamination of medical equipment, water supply, and waste management. So this is just a bird's eye view of the IPC capacity. It's a rapid assessment tool that would help us to identify any gaps. Then we move to infection prevention and control at home. As a WHO, we recommend that one completes antibiotics and is rendered non-infective before they mingle with the community. But in some maybe cases in a facility, you may see that some children are maybe discharged home. So again, for IPC now, these are the advice we give. We ensure that the room is well ventilated, and we limit the number of caretakers, and we ensure a distance of 1 meter and limit patient movements. Again, we encourage caregivers to use medical masks when they're within 1 meter and perform hand hygiene and respiratory hygiene appropriately. Even cleaning and disinfection of utensils, frequently touched surfaces, clothes, and beddings are really critical. Again, the contacts need to be followed up on the issues of prophylaxis and the issues of vaccination. But we will also hear again from case management in terms of the discharge of patients. But what I am confident is it's important for completion of antibiotics, because, you know, children, you cannot restrict a child in one area. They are likely to touch everything and run around, and they are likely to amplify infection. So case management would really want to emphasize on the completion of antibiotics. So for health worker exposure management, as we said, it's critical that our healthcare workers are trained on standard and transmission-based precaution. And for this disease at hand is diphtheria. Yeah, and also they need to be trained in identifying and isolating suspected and confirmed cases. This is a huge gap. Yeah, so we talk about general IPC, we talk about COVID-related IPC, but we are not talking about diphtheria. We're not talking about other infections. And even you move to an isolation unit, you find there are multiple diseases within that area. You find there's measles, there's whooping cough, there's diphtheria, and so on. So we need to also see what are the IPC precautions for the standard and transmission precautions for that isolation facility, and see how we can work as IPC to ensure that we are separating these patients, because we would not want one patient to have the multiple infectious diseases, because the likelihood of the prognosis would be poor for such cases. Again, one of the challenges we see, we are not monitoring health worker exposure. Yeah, we need to ensure that our health workers are adequately vaccinated, including having received booster dosages, and we need to have protocol for assessing and managing occupational exposures. Yeah, and the health workers, they need to be provided with information on signs and symptoms, monitoring, and also seeking early medical care. This includes also the hygienists and other support staff. Yeah, and those who develop symptoms, they need to be excluded from work duties. At times, you may go to a facility and even find a health worker has an IV cannula, yeah, is on erythromycin. So we need to ensure that they are excluded and they are not penalized for that. And for those who have confirmed, then they need complete antibiotics. And once they are free from infection, then they can go back to work. A high surveillance, again, we need to monitor inpatients for signs and symptoms of diphtheria. Yeah, so we need to look at the high diphtheria, that is the healthcare associated infection for diphtheria. What is the case definition? Yeah, so a case of suspected or confirmed diphtheria with recent exposure to a patient with a suspected or confirmed diphtheria is likely to have developed a healthcare-associated infection for diphtheria, or if you've been cared for by a healthcare worker who has suspected or confirmed diphtheria in the last 10 days, and after a review that finds no evidence of potential exposure in the community or household. So again, those are the things that we need to look out for. We need to document because this actually the outcome, if you have high diphtheria infection among health workers, then already it tells us that the IPC practices are not appropriate. So let us ensure that we are conducting high surveillance. Again, IPC plays a critical role in vaccination. Let us work together with the vaccination to ensure that we have standard precautions applied to and additional IPC precautions, because the outbreak at hand is diphtheria. We need to screen these patients before we vaccinate, and we need to have appropriate PPEs for the health workers who are conducting vaccination. So, the mask and so on. Okay. So that is it from me, and thank you very much. Over to you, Dr. Olaolu.
Thank you so much, Dr. Deborah, for the presentation. Thank you for taking us through the essence of breaking the chain of transmission, which is very important, breaking it within the health facility and also in the community. I know respiratory hygiene is very important, and with the epidemiology of diphtheria, we find that there are more females having it. So females are more or less the primary caregivers of persons. So this needs to be put into practice to ensure that we reduce this trend of persons coming down with diphtheria. Many thanks So we'll move to the next presentation, which is on risk communication and community engagement. This is really a very good link from the infection prevention and control we've had. And this will be taken by Ms. Aminata Kobe. Aminata, over to you.
Sorry, good afternoon or good morning, depending on where you're watching me from. I will say that I'm happy that the technical colleagues have presented, and now is the time for risk communication. And I think this links very well, knowing that colleagues have presented technical terms, they've presented technical issues. How do we link this to members of the community that might not fully understand what is being said? So I'll start off with the definition of, I'll start off with the definition of risk communication, which is a real-time exchange of information, advice, opinion between the experts, officials, and the people who face the threat. In this case, we are talking about members of the community. It is very important for the technical colleagues, the experts, to be at the same level with the communities that are affected and who face the threat, so that they are able to take informed decisions to mitigate. The previous presentations, we've spoken about preventive measures, such as vaccination. We've spoken about IPC at the health facility level, at the home level. We've spoken about treatment. It is key for members of the community to understand what are the risk factors, what are the signs and symptoms, what are they dealing with, when, how, and where should they report about the signs and symptoms. So for the technical colleagues and the people that are being affected to have the same understanding, so that the people can take action, the communities can take action at the correct time to prevent themselves and their families and their loved ones, so that they are able to break the chain of infection. As we are all aware, outbreak starts and end at home and community level. So if the people at the community level are able to understand what is going on with them and how they can contribute to prevent and stop the outbreak, then we will be able to say we've really done a very good risk communication. So now I'm presenting the overview of the risk communication model, which we've been using. The first aspect talks about the system. There should be a system strategy. So once there is an outbreak, or you are living in a country that next to where there's an active outbreak, there is a need for you to look at the systems for risk communication and community engagement. This involves the plans, development of the plans, the strategies, the SOPs, the human resources. All these need to be looked at its entirety, even as we prepare for the outbreak, or we've just started responding to the outbreak. There should be a mechanism for internal and partner communication and coordination. We should be speaking the same words. We should be talking to the community words that are similar. We should not be talking against each other, or else this will affect the trust of members of the community. Are we sharing the same preventive measures? Are we talking about the same issues when people should go to the health facility? Are the health facilities prepared enough to be able to receive members of the community that show up signs and symptoms? We also need to prepare and implement public communication. This should include media communication, social media. This has to be specific and it has to be contextual. the risk communication public communication plan for an urban area or an elite area should not be the same public communication plan for a community that does not have access to internet, that has challenges with listening to the radio. So it has to be adapted to the specific area that we want to target. We also need to engage communities so that they know what actions they need to take to prevent themselves and their loved ones, and for us to understand what are their challenges and work with them so that we empower them to take action. The issue of dynamic listening, either using social media or using other traditional methods, is key so that we listen to what the communities are saying, what challenges they are facing. There is an issue of vaccination. Why are people not receiving vaccination? So if we can listen to them and understand what challenges they are facing, then we can include these challenges and this feedback into our strategies so that we are able to reach people and stop the outbreaks in the communities. I'm presenting this to show how risk communication has evolved. Before, we think that the communities don't know, so we keep quiet about what is happening. We don't announce early. It moved on to an era where we think that the public does not know and they will not understand what is happening now. And we know with social media, the community knows a lot. And if we don't announce to them early and guide them on what actions they should take, it's a challenge. We moved on to the mass communication era, listening to the social media era, and now we are in the era where we are assessing the public knowledge perceptions and we are incorporating it to our public communication and community engagement. We are still learning in the area of risk communication to see how we can continue to improve ourselves so that communities are empowered to take actions at the home level to prevent themselves and protect themselves and their families from infection, and to take actions that will break chains of infection. So it depends on which stage you are at the outbreak. Either if you are preparing for an outbreak or you are at the stage where you're evaluating, there are certain actions that needs to be taken. If you are at the preparation stage, you need to build a relationship with the community. Building relationship with communities is very important to build trust. And this is very critical, especially if we are looking at health workers, community health and facilities, where there needs to be a relationship between the health facilities and the members they are serving, either for preventive measures, like in the case of diphtheria. Now we are talking about the issue for us to increase immunization rates. So if there is no relationship for the health worker to understand what is going on with the communities and how to mobilize the communities so that they can increase the immunization rates. And we need to prepare standard messages, and these need to be adapted based on the feedback we are receiving, and we need to monitor what the media is saying and be able to adequately respond and also to be able to respond timely. We need to adapt the messages or the strategies to the affected populations, so that we see we are relevant and we see what is happening and are able to respond and adapt adequately to the prevailing situations. We need to engage with audience and get feedback and adapting our messages, as this has to be happening regularly and frequently throughout every aspect of the outbreak cycle. And we need to conduct health education, collect feedback, and promote the different agency activities. And the evaluation of the risk communication and community engagement and lessons learned, this has to happen regularly, and we have to input it back to the activities we are doing. So now we are looking at some of the barriers that we've seen to uptake of public health measures at community level. One of them is the lack of knowledge of how the disease is being transmitted. And from the presentation from technical colleagues, we've seen that the disease is being transmitted because people have failed to be vaccinated, which is very key, and also because of the environmental situations that they are in. Some households are not good enough for it to be ventilated well. So we need to really transmit this information, and this has to be evidence-based, because if we are monitoring the surveillance information, then we'll be able to communicate the risk factors that are prevalent in that specific environment. So we need to learn and communicate these risk factors to the public so that they understand. And we know another challenge is the issue of trust. There's a lack of trust between health workers and the populations they are dealing with. And sometimes what causes this is that the health facilities, they normally discuss with the communities, and now when we have outbreaks, we have people that the communities have not been used to coming back to them and working with them. So it's good for us to maintain consistency during prevention and also during response to outbreaks. We also have the issue of some channels of communication that are being used do not reach some groups or population that are being affected, either because of language barriers or the means of communication that is being used. They don't have access to this. So it's good for us to be able to really do a very good situation analysis to know which populations are we targeting. Are we getting to them the messages that they need to protect themselves and their families? If not, can we try other strategies so that no one is left behind, even as we are trying to transmit our messages? So some of the best practices is the issue of announcing of the outbreak early, so that people know what is happening to them, and this helps to build and maintain trust. We also need to share information about the disease, especially the situation among health workers. Sometimes we think that health workers know what is happening, but also we need to target the population at risk so that they know what is happening and know how to prevent themselves. We also need to be proactive with information, to share how many cases are there in the communities, and to always give frequent updates, maybe through press releases, through radio discussions, but by whatever means that we need to provide frequent and regular updates to the affected communities. We also need to ensure that our materials, the messages that we are passing, should be easily understood, and we should be using the channels that are preferred by the communities. Is it that they prefer to get their messages maybe through their religious leaders, or through radio discussions, through community meetings? Whatever method they rely on and is more common to them, we have to use this method. And we need to listen, identify, and manage rumors and misinformation quickly. And we need to use a mix of methods so that we don't leave anyone behind, and we are able to reach all the communities and the relevant people. We need to work with the media. It is very key, so that even as they are passing on their normal transmission, they are able to pass on key health information. We need to continue using public statements and announcements, and definitely we know that communication has to be two-sided. If we are reaching out to the communities, we need to listen and find time to also hear from them what are their concerns and their challenges to take up the public health measures that we are asking them to do. We need to create mass awareness initiatives and mobilize them and engage them. Not only engagement with the community, but we also need to engage other partners that are working with the community. Some other tips on communicating, I've said that we need to be proactive. We will not wait until the communities have rumors, but we need to announce early and be consistent in informing the communities. We need to plan in advance. We also need to identify and understand the audience and the affected communities. We need to use the channels of communication that they have been used to. Whenever we are passing on messages, we need to first test the message. We need to be consistent and coordinate with other partners so that our messages are the same. We are not telling people different messages. We need to build relationship with the media and the key influencers in the communities. The influencers might be different based on the context and the communities we are working in. So we need to find who are the influencers for vaccination in these communities so that we work and use these influencers to transmit our messages. We need to ensure that we are collaborating in terms of the intervention with other pillar leads. We are collaborating with the case management team. We are collaborating with the immunization team. We are collaborating with the IPC team so that we are all working together as a team. And we need to collect and incorporate feedback even from the different pillars to the response activities. I have attached some relevant information so that you'll be able to link and read more on risk communication. Thank you. Over to you.
Thank you so much, Aminata, for that excellent presentation. Thank you for taking us through the processes. The community engagement is very important, and one of the key things you highlighted is the preparation even before an outbreak occurs, which is very critical. You need to have the confidence of the community before it occurs, and how we now use the information we have to ensure that the community understands and they can take the expected action for to be able to control the outbreak, to reduce transmission, to reduce morbidity, to reduce mortality. And at the end, an evaluation needs to be done, which you also emphasize, which is very important so that it's more or less to be a learning process for the risk communication team to be able to work much better. Thank you so much for that. We'll move to a session of videos on how to collect samples. I think our IT team will come on board to share that. So there are 2 videos that will come up.
Can you hear the sound of the video?
No, we can't hear now.
Okay,
No
let me do that again.
Among other things,
is it
the
okay
examiner
now?
should wear an
Yes,
N95
yes,
respirator
okay.
mask. It is essential to follow proper infection control measures when samples are collected from patients. Among other things, the examiner should wear an N95 respirator mask, a gown, protective goggles, a face shield, and gloves. For demonstration purposes, this video will only show the technical details of sample collection. Before we begin, let's discuss a few tips to minimize patient discomfort and risk. Nasopharyngeal sample collection should only be completed using proper swabs with a longer, flexible plastic shaft. You can identify this by the location of the breakpoint, which is further away from the cotton swab compared to the oral pharyngeal swab. Swabs with wooden shafts should never be used as they are more likely to cause patient injury and discomfort. Hold the swab like a pin between the thumb, index, and middle fingers. Maintain a loose grip that allows the swab to accommodate any resistance encountered during sample collection in order to reduce the risk of injury. Avoid the following hand positions during sample collection, as all of these increase the risk for injury to the patient. Before inserting a nasopharyngeal swab, it's important to have the patient tilt their head at 70 degrees. This angle will straighten the passage from the front of the nose to the nasopharynx in order to make insertion of the swab easier. You can support the patient's head with your non-dominant hand by cradling the back of their neck area. However, do not hold the patient at the back of their head. If necessary, lean the patient's head against a wall in order to minimize jerky movements. To begin a nasopharyngeal swab, the patient should sit in a relaxed and comfortable position during the sample collection process. Allow the patient to blow their nose first in order to remove any excess secretions from the nasal passage. Stand slightly offset from the patient to avoid the risk of contamination in case of sudden cough or sneeze. Be sure to advise the patient of potential discomfort during the sample collection and let the patient know that they're welcome to close their eyes. To collect a sample, remove the swab from the packaging and tilt the patient's head back. Slightly start by inserting the swab horizontally into either the left or right nostril. Carefully advance the swab while maintaining a course that is close to both the septum and the floor of the nose, parallel to the palate. Do not advance the swab upwards, but instead straight back until resistance is felt as the swab reaches the posterior nasopharynx. When collecting samples from an adult patient, this corresponds to a travel distance of approximately 2 inches. The swab should reach a depth equal to half the distance between the nostrils and the outer opening of the ear. When inserting, if you detect resistance to the passage of the swab, simply back off and try reinserting at a different angle, closer to the floor of the nasal canal. Alternatively, you may try reinserting it into the other nostril if a deviated septum or blockage creates difficulty in obtaining the specimen. Once inserted, leave the swab at this depth for a few seconds in order to absorb secretions. It may be recommended to gently twist the swab shaft several times as well. Once completed, slowly and gently remove the swab. There's no need to repeat this collection in the other nostril if the proper sample was obtained. Let's watch this again from another angle. Once the swab is removed, immediately insert it into the sample collection tube or manufacturer packaging. Once this is inserted, break along the groove or the break point. For tests requiring direct processing, follow the manufacturer directions. Properly discard whatever remains of the swab. This video demonstrates the collection of specimens from the surface of respiratory mucosa with nasopharyngeal swabs in both adults and children. Remember, it is important to use approved PPE and the appropriate technique in order to minimize the possibility of spreading any virus.
Je passe à la vidéo suivante. Should I go to the next video?
Yes, please, go ahead.
Okay.
It is essential to follow proper infection control measures when samples are collected from patients. Among other things, you, the examiner, should wear an N95 mask, gown, protective goggles, a face shield, and gloves. For demonstration purposes, this video will only show the technical details of sample collection. Before we begin, let's discuss a few tips to minimize patient discomfort and risk. When conducting an oropharyngeal swab, it is important to have the patient tilt their head at 70 degrees. This angle will straighten the passage from the front of the mouth to the back of the throat, allowing you to see inside the patient's oral cavity. Be sure to advise the patient of potential discomfort during sample collection and let the patient know they are welcome to close their eyes at any time. It is also important to explain to the patient that the smear may feel uncomfortable for a short time and may trigger the patient's gag reflex. Position yourself slightly offset from the patient to avoid the risk of contamination in case of sudden cough or sneeze. However, stand where you can see directly into the patient's oral cavity so you have a clear view of both the mouth and the throat. To begin the oropharyngeal swab, the patient should sit in a relaxed and comfortable position during the sample collection process. First, allow the patient to take a deep breath and exhale. Ask the patient to open their mouth, protrude their tongue forward, and say, "Ah." Using a tongue depressor, gently press down on the patient's tongue, revealing the posterior pharynx or the back of the throat. Insert swab into the posterior pharynx and tonsillar areas. Rub swab over both the posterior oral pharynx and the tonsillar pillars for a complete collection. Be sure to twist the swab shaft thoroughly, yet be very gentle as to not irritate the patient's throat. Avoid touching the patient's lips, tongue, teeth, hard palate, or soft palate in an effort to protect the integrity of the sample. Once the sample has been collected, remove the swab from the patient's mouth. Insert into the testing tube and break along the groove or break point. For tests requiring direct processing, follow the manufacturer directions. This video demonstrates the collection of specimens from the surface of the oral mucosa with oropharyngeal swabs in adults and in children. Remember, it is important to use approved PPE and the appropriate technique to minimize the possibility of spreading any virus.
Okay, great. Thank you. I hope we all learned from the video demonstration. So we thank all our colleagues for the presentations they have made. So we move into the question and answer time. As we said, we'll give priority to our Portuguese speaking colleagues to ask their questions first. So kindly raise your hands electronically so that you can be unmuted. So we have two persons on the chat. So we have Kevin Yohu. Yes, kindly unmute yourself. The IT will also support. Kevin Yohu. And to be followed by, okay, Keita.
Bonjour.
Kindly speak. Yeah, bonjour. Yeah, go ahead.
Bonjour. Je suis Dr. Keita Fatmata de la Guinée. Je suis épidémiologiste de terrain, membre de l'équipe des urgences de l'OMS Guinée, basée à Conakry. En fait, nous sommes en épidémie, comme vous le savez. Pour le laboratoire, j'avais déjà posé la question dans la boîte pour savoir, est-ce qu'il faut systématiquement prélever tous les cas suspects de la diphtérie, parce que généralement, ce sont des enfants. Mais en plus de ça, est-ce qu'il est nécessaire de faire les deux tests obligatoirement pour chaque patient? Merci.
Okay, thank you so much. Let's move to Satu. Sise. Yes, Satu, kindly unmute. Satu, could you IT kindly support in this?
Yes, she can unmute herself. Her microphone has been activated, but
Okay.
I think we can go to the next one.
Okay, Sondagi. Yeah. Sondagi, yeah. Well, okay. Seems to be having some challenges there. The next person is Lextra Muyeng Yembe.
So to unmute yourself, you have the icon of the microphone down on the left. Just click once on this icon and you will activate your microphone.
So colleagues, could you just kindly do that? Satu.
Excuse me, for me it's okay.
Okay, we have lecture.
Yeah, it's okay. Yeah.
Yes, lecture, go ahead, please. You can talk. Unmute yourself.
No, I'm saying it's okay.
Okay, it seems it doesn't have a question again. Okay, so well, Sodangi, could you speak? Yeah. Okay, it seems all the hands are now down. Okay, so we have a question for the lab team. Could the lab team could respond to that? Yeah. Rachel, on systematically collecting samples, the guidance for countries. Yeah, Rachel. Yeah.
Sorry, are you able to see and hear me?
Yes, we can. Yeah, go ahead.
Okay, just to mention that the current diphtheria guidelines are being revised and a new guideline will be out soon, probably by the end of this month. But as we know, diphtheria can be tested in the lab, but there's also the clinical aspects of diphtheria where you can just use the clinical method to determine if the patient is sick. So even Emma had put some of the options in the Q&A just to let us know there are different ways of detecting it. So we cannot expect all samples to be tested depending on the number of samples a country is able to collect at a given.
Oh, hello. Seems I can hear you from here.
Yes, she's having some issues with internet.
Well, okay. Okay, well, since I don't know, Emma, are you online? Well, you can. I think I also want to add to the question. There's a question in the chat box. So what other considerations will be made in collecting samples for children? You know, the video has shown how to collect for adults. So for children, what other considerations need to be factored in to collect the samples properly?
Okay, so to echo Rachel's response, yes, we have other options for diphtheria confirmation. So we do not limit it to laboratory confirmation, and this depends on the resources you have in the country, because you will not be able to test for all the cases because you may not have reagents. So yes, I'd like to echo Rachel's response to that. Then for the samples for children, I would like to talk from experience in Nigeria. It's not realistic to collect nasopharyngeal swabs from children. They will not even allow you collect that. So what we do here in Nigeria, most times we collect just oropharyngeal swabs or throat swabs for now. Then for the media to use to preserve the samples, in Nigeria we use Ames transport medium and Caribbean. I'd like to also highlight that initially because the protocol says Ames transport, so we had to explore Caribbean medium because that was what was available in the country. And this Caribbean medium can also be prepared by the local laboratories. So we're advised to just use what is applicable in your own setting. So our advice, you can also explore Caribbean medium, which is actually cheaper than the Ames. Yeah.
Okay, great. Thank you so much for the response. Probably we can just take one more, then probably I'll just ask Professor Peter to more or less help us wrap up based on the various presentations and the questions that have come up in the chat. But meanwhile, let's take Seno Amuzo. Kindly unmute your mic. This will be the last question.
Okay. Thank you very much for the presentation and all the sessions. Really appreciate it. I'm Seno Amuzo, Incident Manager from Guinea. As you know, we have a diphtheria epidemic ongoing now. So my question is that we noticed that we have a large amount of people, about 40% of sick people are aged over 15. So what will be the advice for targeting people for the vaccination in the big catch-up? So are we going to limit our vaccination target up to 5, up to 15, or over? So thank you. Thank you very much.
Okay, all right. Thank you, Amuzo. So, Sheila, could you answer the question? It talks about vaccination. What should be the strategy for the catch-up and also for the response, using Guinea as an example?
Well, for response, usually we are looking at the disease in question, like in this case, diphtheria. So it's focused on diphtheria, but we also use that to catch up on other individuals that have missed or under-vaccinated or have never been vaccinated against diphtheria. Although in most cases, catch-up involves catching up on even other antigens besides diphtheria or beyond DPT. So for the response, we mostly focus on the diphtheria response or diphtheria-containing vaccination to try and control the outbreak, but we also use that opportunity to catch up and also include even other antigens, depending on the resources available in the country and the vaccines available.
Okay, all right. Thank you, Sheila. Okay, great. Thank you, Sheila, for the response. So I'll call on Professor Peter, who is our head of operations and technical expertise for the diphtheria response at the incident management support team in AFRO, to help us do a wrap-up and also to address some of the issues that colleagues have raised. Someone raised the issue about giving some historical perspective about the diphtheria outbreak in the African region. Professor Peter.
Yeah, thank you very much, Olau. Can you hear me?
Yeah, we can hear you. Can you switch on your video?
Okay, thank you very much, Olau, and thank you very much, dear participants and facilitators. We have reached, at the moment, we have reached more than 300 participants. That means that this subject is very, very relevant, and people are taking really that in consideration. So it's really important. We have seen that really efforts have been done in the countries, supported by partners, but really we need engagement of Ministry of Health and all the local NGOs in the countries. It's really important also to have community engaged. You have seen that it's really important to not delay the treatment. That means that we should really improve active care stage in the community. It's very difficult to really have funds for that, but it's really important to reduce the risk. So first, active case research to reduce the delay and start the treatment very early, avoid to treat patients out of hospitals. And in hospital, it's really important to have isolations because this disease is very contagious. That means that other patients in the hospital can be affected, including health workers. And we have noticed some health workers affected in some countries. So pay attention of these diseases should improve, as we have seen. Prevention and disease control is very important. Talking about vaccination, really is vaccination that will stop this disease, because vaccination is the main factor when we have unprotected children. And now we have more than 20 million in Africa, sub-Saharan, zero dose, and those who not completed their vaccine. And you have seen that we don't have, quite in all the countries, we don't have this booster dose. So we need really to seize opportunity of catch up, to really focus mainly in the area where you have the risk of diseases or where you have outbreak. So all the countries are engaged in this big catch up. So let's first prioritize this area, and then without forget to continue with the other one, because the other one are also at risk. So the second point is about the case management, the treatment. It's really difficult to have GAT because at the international level it's very rare, and WHO is really makes effort to distribute, taking in consideration equity. So that wise we used to really administer this GHC when the cases are complicated or when we have respiratory cases. So it's very important to continue to treat people with antibiotics, but we should also know the sensitivity of these antibiotics. So let's see how you can mobilize funds in your countries, seize opportunity of really converted COVID-19 remaining funds to focus on this one or any other opportunities. Concerning this training, it will be also good really to cascade this training. We will share all the representation that was done this webinar. So let's share this one. Let's continue to do also supportive supervision in order to increase the knowledge. And don't forget to extend your isolation when it's very important. So thank you very much, colleague, and courage to continue to really improve this response in your respective countries. And we are also encourage partners and also colleagues to really support Ministry of Health and Community. Thank you very much. And I think we can close this webinar. Thank you, Olau.
Thank you so much, Professor Peter, for wrapping up for us. And thank you, colleagues, for joining this. The participation has been really very engaging. Several questions came, more than 40 questions came up. We really appreciate your time in this. So this is the second webinar we've had, and we're growing close to the end of the year, but we are still responding to this outbreak. So as we respond, let's also keep ourselves safe as health workers in managing these cases. So we'd like to say have a blessed day, wishing you a happy new year in advance. We may not have another webinar before the next year, but the communications will still go on. As Professor Bita mentioned, we'll be sharing the materials that were presented today. So thank you so much and have a great day.